We started about 10 minutes late. We'll probably finish about 7 minutes late. And this will be a little bit shorter than was planned. So I'm going to talk about the independent or private sector. And I think this is an important area, and I think there's some important messages. I'm going to play it completely straight. So it's chapter 23. And this is the first time that we've included the independent sector in the National Audit Project. It was decided that we should make every effort. It's previously been recommended that we should include the independent sector in the National Audit Projects. They're part of the healthcare system, and we made every effort to do that. NHS care within the independent sector has become increasingly prevalent. So in 2017, 45% of independent sector patients were NHS funded. That's probably increased. Orthopaedics, my expression of interest, I do work in the private sector as well as the NHS, but not very much. Orthopaedics, 25% of private hospital surgery. The hospitals are smaller, they are isolated, and they are competing against each other and against the NHS to a certain extent. There is, in general, in my experience, I think in most people's experience, a lack of departmental structure in many private hospitals, where individuals may have practicing privileges or admission rights, and anaesthetists may work as what's been characterised as lone wolves, working as individuals, perhaps in competition with each other, or in anaesthetic groups of all sorts of different shapes and sizes and types, which may or may not collaborate with each other. I think it varies a lot. So what did we do? As I say, first time we've tried to engage the independent sector. We asked for the Association of Independent Healthcare Organisations, so their organisation, to tell us which hospitals we should be contacting, and they used appropriate data to give us a list of hospitals. The then President of the Royal College of Anaesthetists wrote on 4 occasions in May 2015 to ask all hospitals to take part in NAP6, explaining what it was, what the requirements were, and we delayed deadlines to ensure that we could engage independent sector hospitals 3 times. There are barriers for them to engage, and I think there are genuine challenges in these hospitals. These are the list of barriers, some of the barriers that they identified. The fact they didn't have an anaesthetic department to coordinate the project, the fact they didn't have somebody who could act as a local coordinator, the large number of anaesthetists, sometimes up to 200, and the variability of their presence, meaning that they couldn't communicate effectively with these anaesthetists, which, if they couldn't communicate this project, raises some other challenges for them in communicating other safety-relevant information. The rarity of anaphylaxis in that hospital, and the fact that the data might be confidential or competitive in nature. So we contacted 304 hospitals on multiple occasions. Eventually 41 agreed to take part, which just got above we had a level of 30 to say if less than 30 agreed we were not going to include them at all. But because there were more than 30, we felt we should. We were very grateful to those independent hospitals that have taken part, particularly grateful because I think they've gone to quite a lot of effort to do so. So that's 13% engagement compared to 100%, and rather fewer than that took part in the organisational survey. So we decided that the information we'd get from them would not be representative, or could not be guaranteed to be representative, so that we've used it as illustrative information rather as quantitative analysis. So you can see the independent sector on the right here and NHS on the left. So we've got a lesser engagement in the organisational survey. Large departments, if you want to call them, are large numbers of people operating in these hospitals compared to the anaesthetic departments, although you'll see that half of those are trainees or SAS doctors. Generally providing the same sort of services as are provided in NHS hospitals, but with many fewer of them. And this, we don't know if this is representative. I suspect rather fewer than 39% across the board have HDUs or ITUs. So they're different hospitals, different sorts of hospitals. And in terms of the provision of local preparedness, there are some areas where their preparedness is somewhat lower than in the NHS, and some areas where it's thought to be rather higher. In terms of referral, when events happen, that certainly appears to be less clear, fewer clear pathways, fewer methods for referral, and a greater reliance on other people to do the referral when it occurs. In terms of the case reporting, so we had these 41 hospitals and hospitals were asked, so the local coordinator, who at the private hospitals could have been an administrator rather than a consultant anaesthetist, was asked to return every month to say, have you had any cases? We've had no cases, we've had 6 cases, we've had 1 case, we've had no cases. And in the NHS, from all these hospitals, 84% gave us 12 monthly returns over the year, and the overall return rate was 94%, and it was somewhat lower from this smaller number of hospitals in the independent sector. So you can see why we don't consider it representative. Were any cases reported? Well, 304 hospitals, maybe 10 or 15% of UK healthcare activity. Surely there should be more reports than this. Well, we don't know what's going on. There were 7 requests for reports. 2 are complete and 5 were incomplete. And this is the information that was in there. Quite a few were quite old. Most were orthopaedic. They were mostly fit. The vast majority had antibiotics, and the majority had muscle relaxants, which we know are the cause of 80% of cases of anaphylaxis. There were severe reactions amongst these, life-threatening reactions. So elderly patients having orthopaedic operations which include antibiotics and muscle relaxants are at risk of anaphylaxis. 3 of the 7 operations were either completed or abandoned. That's probably proportionately, the numbers are very small, but probably proportionately rather more that didn't get abandoned than in the NHS. And fewer than in the NHS proportionately, but they're very small numbers and not representative, went to ITUs. But these patients do have to be transferred to an ITU, which there may not be on that site. None were reported to the MHRA. So anaphylaxis is, unlike a lot of, so people will select out, quite appropriately, high-risk patients, high-risk airways, high risk of cardiovascular disease, high risk of renal disease. We'll select these patients out and not choose to operate on them in the independent sector. But you can't really select out patients who might be at risk of anaphylaxis. It's unpredictable, life-threatening, infrequent, but predictable enough to know that it will happen in your hospital if you do enough operations. And the patients are going to be exposed to the high-risk drugs, so it will happen. It requires expert, timely, coordinated, and often multiple individuals working in teams to resuscitate and save the patient's life. And it typically needs admission to critical care for 24 to 48 hours. It also, these cases need referral and investigation, including follow-up and reporting. And I think these pose challenges to hospitals in the independent sector. So there was a challenge with engagement, and I think there are challenges with governance. So is everybody trained in a independent sector hospital, both the nursing staff and the consultant anaesthetists working there and the surgeons working there to ensure that it's safe? Is there communication by the organisation? I think they've already told us that they may have difficulty communicating. How is team working in crises in a small, isolated, independent hospital? And will another anaesthetist be able to come or even willing to come to help out if difficulties arise? Are there anaesthetic departments? Well, I think the answer is in the vast majority there aren't. And if there aren't, are there protocols and SOPs? Are cases when they happen discussed at M&M as we recommend and as they should be in the NHS? Further, are vasopressors immediately available? 50% of patients requiring vasopressors after grade 3 to 5 anaphylaxis. We recommend that glucagon and vasopressin should be available within 10 minutes of these events. Are those going to be available in a private hospital? And critical care transfer, the people with the right skills to transfer, and as we've seen, referral and reporting on is not happening very well. So there are challenges for the independent sector, and I think it raises more questions than answers, because in spite of our efforts to get the independent sector to engage, we haven't had that engagement. I hope this will be the first of several NAPs where the independent sector will be involved and the engagement will increase step by step. But we don't know enough. We know enough about the NHS to very much characterise what happens in the NHS, and therefore what the challenges in the NHS are, areas to improve. We don't know enough about what happens in the independent sector. There's a lot of surgical work going on there, and I think we should know more. Thank you very much.